Welcome back to the Stein podcast series. Today we have Dr. Nick Ramsey visiting from the Netherlands. He's a professor at the University of Utrecht and the University of Radboud, where he has directed brain-computer interface studies for the last couple of decades. Today we wanted to ask him about ongoing projects that he has with patients who have ALS and other disabilities that take away their ability to communicate with the outside world. Welcome to the Stein podcast series.
Thank you. I'm happy to be here.
We've got a Stein for you to take home with you. If you don't know what Stein is, it's a Society for Technology, Engineering, and Innovation in Neurosurgery, although now it's expanding maybe to neurology and neuromodulation and neuroscience. And it started when I was a resident, actually right before I came to visit you for the first time, when we thought it would be really good, just Dr. Ogeman and I, you know Dr. Ogeman, Jeff Ogeman, who actually you were a postdoc with at the NIH. We had this idea of starting this thing where we would bring these mugs, Steins, hang out at neurosurgery meetings with groups of people who implant devices and talk about neuromodulation and spend time just talking about what other people do. And so for my own practice, I learned a ton of information about all the little tips and tricks that don't make their way into the literature or into things you could identify online. And so it sort of has continued. These are actually all the Steins since going back to 2016. And that was shortly after I left Utrecht, I guess, after my first year with you.
Huh.
So anyhow, welcome to this undisclosed location in Rochester, Minnesota. Can you tell us a little bit about yourself, how you got into science, what about growing up made you a scientist?
Okay. Well, again, thanks for inviting me. I really enjoy this. I enjoy being in this undisclosed location. So I studied psychology. I started physics, actually, technical physics in Delft, and after a year I figured that's not what I want to spend my time on for the rest of my life, so I switched to psychology. I got interested in Freud at the time, but towards the end of psychology I noticed that I was really much more into experimental work. Ended up doing a psychopharmacology PhD, doing rat research. Didn't want to continue with that, wanted to switch to human work, and that turned out to be very difficult within Europe, where you're kind of marked as an animal researcher. And by kind of chance to my supervisor, I ended up at NIH, and I spent a couple of years there, got involved in first PET imaging, like positron emission tomography in humans, and then ended up with the Dutch mafia. There's a bunch of MRI experts that were setting up an MRI program or building it up at NIH, and got involved in the beginnings of functional MRI. That brought me into trying to understand how the brain is organized. Pretty soon there was an opportunity to go back to Holland. There were family reasons to go back, and the opportunity to have a job there to start a research group in psychiatry.
And that was in Utrecht?
That was in Utrecht, Medical Center Utrecht, and I've been there ever since. I went back there in 1995 and became a professor in 2008 at the neurosurgery department, because with fMRI, being in psychiatry, doing research on what might be wrong in schizophrenia, I was approached by a neurosurgeon, Kees van Velen. He's well retired now, but he did functional neurosurgery for epilepsy, and he was super interested in figuring out which areas to be careful about. So I went into the surgeries to help him out, did fMRI. And
so he brought you as an imager,
yes,
to look at representation in the brain,
yes,
for speech and language before resections, independent of anything electrophysiologic, even though it was an epilepsy neurosurgeon.
Yes. So he was really interested. He needed some help during the surgery to figure out how he can speed up the process of finding eloquent cortex, so he knew where to stay away when he would resect the source of the seizures. So we were in the OR a lot together. The digital means were not that great at the time. You didn't have navigation equipment, so we'd stand together and figure out which area for him to put the stimulation electrodes on to confirm this. That was great. But then at the time, the epilepsy program started to evolve, and they started to do ECOG with grids, and I was super interested in that, because no matter what, functional MRI is kind of woolly. wishy-washy because you're never sure what's happening. There's all kinds of artifacts, and this was just clear, clean signal, and I got drawn in very fast. And then only a few years later, I felt that I could trust what I was seeing there so much that I figured, okay, now I want to make this useful. And then I ended up running into a poster on rats and BCI at SFN in 2003, I think. Got interested in BCI, and then I saw the human work started to be presented there, which was John Wolpaw with EEG, and then a little bit later the BrainGate group with their implants. And started to get grants, put a group together, and the rest is history.
Okay.
I'd say.
When you made that switch from psychology into neurosurgery, you mentioned you became a professor in 2008, but you actually started there many years earlier.
Yeah.
What we call a professor in the US and then what it means to be a professor in the Netherlands are a little bit different, right?
Yeah, they're different. Yeah.
Can you explain that?
Yeah, so in Holland, you have assistant and associate professor, but that doesn't give you the right to call yourself a professor. It's they call it a junior lecturer or a senior lecturer. It's a little bit the same in Britain, I think. So I started as a junior, and then, I don't know, 98, I was a senior lecturer. And then I was doing the work with the neurosurgeons while I was hired at the psychiatry department. And at some point I decided to make the switch. And then there was, serendipity. There was the epilepsy program had a pretty bad audit. There was an audit of all the research programs. And so I was asked to step in and kind of up the research in there. We did a lot of ECOG research on basic human functions like language, working memory, and later motor and sensory. So there was an opportunity for me to step up, and I did that wholeheartedly and left psychiatry behind.
Was it pretty easy to leave that behind, or do you miss your psychiatry work?
None of it.
No? Okay.
Not because of that. Not because that's not interesting.
Yeah.
It's that's really tough to try to figure out what kind of cognitive deficits there are, try to find targets for drugs and everything, and that's a problem. It's perhaps a little bit too much for me. So when you work with electrophysiology, it's more tangible. You can manipulate, right? You can stimulate, you can record, you can look at behavior. All that's not available in psychiatry. Well, the problem of trying to figure out where the problem is and what the nature of the problem is just very undefined. So I regard psychiatric research harder than the work with neurological patients. Yeah.
Kind of got pulled back towards your physics roots, I guess.
Yeah, a little bit. Yes. I've never been afraid of doing math. I really liked coding at the time. I did a lot in IDL for functional MRI and stuff. Unfortunately, it eats away time, and I decided I was better at getting grants and guiding people than spending my time on coding. So I unfortunately have no idea how to code anymore.
So when I first came to see you, it was 2007.
Yeah.
You knew Jeff Ogeman, who's a neurosurgeon in Seattle.
Yeah.
And I sent you my first paper, which was on movement in electrocorticography, and you guys were doing some similar things already. But when I came to visit you, you had one branch, which was electrocorticography, which is these implanted electrodes. Right. But you had another branch of the lab that did fMRI, exposing people to recreational drugs and that kind of thing, right?
Right. Yes.
Can you tell me? You couldn't really. It'd be hard to do that in the U.S. I mean, I guess they do it under very controlled conditions.
Yes.
What was that like there? How did you do that?
Well, when you research in psychiatry, so it was a carryover from psychiatry, and when you work there, it's always a mix between imaging and pharmacology, because that's the only way that you can treat them, or at the time. And so you get opportunities where people approach you to be part of consortium. This was a large consortium, and we decided we were very interested in figuring out what the effects of cannabis were on cognition with functional MRI. So we ended up doing a study with, I think, 20 healthy volunteers where we would administer cannabis or a THC vapor. We bought a machine to do that, so people would inhale it in a scanner. It was quite a logistic challenge. And they would get stoned in the scanner, the certain dose and everything, and we would look at whether their working memory networks would behave differently and stuff. So that worked out pretty nice.
But there's a lot of open marijuana use in the Netherlands anyway. So did you have to have a decontamination room before you brought them into the fMRI?
Yeah. Well, yeah. So it was funny. So in the streets you could buy at the time, and even now for maybe for a few euros you could buy quantities. But then when you go into formal research, suddenly you have to go through institutions that have purified TNC, and we paid an obscene amount of money for those little vials that had exact doses, and they turned out not to be exact. But so it's a different world. Once you step into the regulatory domain of things, then everything becomes expensive. And I remember we had randomized, people would come in twice, and then you would have saline without anything, vapor, and versus the THC vapor. The saline vials, they cost like 50 euros each, like $50 each. And it's like, okay. Anyways, that was nice, but it's very intensive, and the end results are incremental. There's no big things that you discover.
So something that's kind of interesting is there's a lot of interest in closed-loop deep brain stimulation now for drugs of addiction and trying to break people from those. And something that I always wonder about is when it comes to a lot of these things that we consider to be psychiatric indications, you take two people and for example, you take two people and you call them depressed, but they can have very different underlying etiologies for what creates that.
Yeah.
When it comes to drug abuse, do you think that the way people respond to drugs is homogeneous enough for us to be able to have closed loop DBS, where we could use something like fMRI to localize where to sense from and then use that to trigger stimulation?
Yes and no. If you think about all the psychiatric disorders that we have and we recognize, I think addiction is one of the very few that is reproducible in animals. So I was working with rats for 4 years to get them addicted to cocaine. That's super easy. You inject, you get a cannula into the jugular vein, and you have a pump that injects every time they hit a little bar. Within a day, they'll go crazy on the bar. So that's a system that you can investigate in animals, and there's been a lot of work on this, the limbic system. And even today, it's like 40 years, 30 years after I did research, it's still about the dopamine and the limbic system. So we know that's the system. How it exactly works, we don't know, but it definitely, of all the psychiatric disorders, I think that might be one of the most likely to be reliable in terms of where you put the electrode, because it's a defined system. So for depression, I think it's a little more complicated. We don't have a good animal model for it. For schizophrenia, even less. Anxiety disorders, maybe. It all depends on whether you have a good animal model where you can actually probe the system, perturb the system, to figure out how important that role is in that particular disorder.
And have you thought at all about going back into, now that you do brain-computer interface, which I guess we can get to in a little bit, but going into using all the tools that we have for sensing neural activity in the disabled, and instead measuring neural activity that responds to craving, that is triggered by craving for, there's a very large number of people, there are a lot more people who are addicted to very serious substances that destroy their lives than there are, for example, patients who are locked in.
Yeah. If I were 20, I would feel that, but I think it's a long trajectory. And part of the reason is that the limbic system is also responsible for our natural feeling of content or happiness. And I think it's going to be a long trajectory to figure out, if you stimulate, what the impact is on the rest of the life of that person. Is that person going to be, deprived of pleasure, natural pleasures? So there's a lot of work to be done there before you can say, okay, this is going to work. So I have a limited amount of time. You need, I think, 2-3 decades maybe to really make it work. So I'll leave it up to others and focus on what we do now.
Okay.
Yeah.
And total aside, but digital addiction that we see now, it seems to be a little different when we go visit, for example, when we go visit the Netherlands, we usually see you while we're there. And then when we're here, the distribution of people glued to their phones seems to be a little bit different.
I don't think so.
You don't think so? You think the society there is responding the same way as here?
Yeah, and I think it appeals. So when you're talking about addiction, people think it's always substances. But already when I was doing the research in the 80s and 90s, we also already recognized that gambling is literally an addiction that engages the same system. And I can imagine that if you max out utilization of human behavior, what people like and dislike, if you capitalize on that really much, you're engaging those systems with more sophisticated ways like social media and things. So you're kind of squeezing the max out of the human system to keep it glued to the screen. So I don't think it's a new problem. It's just a new look of a problem, a new context.
Yeah.
But it's still the same human beings. And we always thought that whether someone becomes addicted to alcohol or cocaine or heroin or something, it just depends on what they were exposed to first.
Do you think that they're the common circuits and then they have
Yeah.
common feeder into a characteristic system?
Yeah, I think so. Yeah.
Because,
yeah.
I mean, you've had patients with subthalamic nucleus electrodes. So let's say
Yeah.
they come from somewhere else.
Sure.
It's not, I didn't put them in. Or
Yeah.
but where they're a little too far
Yeah.
into, a little too ventral in STN. And
Yeah, so we see that if you're stimulating limbic STN, we'll see typically that's mania, but I actually just saw a patient last week that had a little bit of behavioral change, a little aggression from the stimulation. So we had to stop it. Went away right away, actually. It was kind of interesting how quickly that happened. And then we moved the field a little farther superior away from because we have imaging now, we kind of know where the leads are, and pulled it up, and we'll see how he does. But
so do you think that the gambling binges people go on from STN stimulation is just a manifestation of mania, or do you think it's people who have underlying propensities for gambling disorders?
it's not as frequent that we see it. We see it more with dopamine agonists. Mm-hmm. So, of course, you're bathing the whole brain in dopamine. People call it impulse control disorder. But I think those folks, sometimes it's people who never gamble and then they really start doing it. But a lot of them are people who've sort of, maybe enjoy it a little. They go there and the story just shifts. Instead of spending whatever, $10 for fun, they go out and they're spending their life savings. So I do think it's a little bit of what people have maybe already found a little pleasurable. And maybe this is a different avenue rather than, this is an artificial addiction, right? You're giving yourself the dopamine as a form of the medication. And in that context, I think it's whatever's there already pleasurable sort of gets amplified.
So coming back to the circa 2005, 2006, 2007 time period, experiments that we were running were collectively similar in that they were based on feedback, usually related to sensory motor, but maybe you can tell us about some other ones, with patients who are implanted for epilepsy. In the epilepsy monitoring unit, they have electrodes inside their brain for a few weeks trying to figure out where seizures start from. And then we would do testing with them. Can you tell me a little bit about how you started that in Utrecht and how it has evolved and changed over time, and without getting into the patient implant, the independently implanted patient aspect?
Yeah, just the ECOG program.
And how the lessons learned there told you strategies that you thought would be successful and have actually been shown to be successful for locked-in patients.
That's a very hard question because I would have to reconstruct how things went. But so I'll just start at the ECOG. So I think in the beginning, what we would do is start to replicate the fMRI workup we did. So if the surgeon said, okay, I'm worried about language regions because, the suspected source is in the left hemisphere. And then we do the fMRI and it comes results. And if people move a little bit, it don't look that great. So I decided, well, okay, let's utilize the grids that are placed in those areas for clinical purpose and see if we can record during the same tasks. So we had to adjust the tasks. We had to get used to being in a clinically constraining circumstance because we pretty quickly felt that we were in the way of the nurses and the neurologists. Of course, they were interested in this, but it was a kind of a split. So we started doing those tasks to help out, give more detailed information to the surgeon. So when you have the grid and you can identify which electrodes light up, so to say, during a task, and we do different language tasks, classical in the like lines of production and perception. And then those electrodes, you mark them, and the neurologist would say, okay, with those areas we don't really want to remove, and that would further inform the surgical plan. But pretty soon we already thought, well, those areas are covered. Why don't we do functional working memory research? That was what I was very interested in, and that kind of my history in psychiatry research, right? This is a short-term memory, working memory. So we started mapping that out, and that allows you to publish papers about these things. And the beauty about ECOG is, of course, that you get, very clear signal changes with the engagement of a particular part of the cortex in time. So you could actually get some temporal information about when it would switch on and things. So at some point, it was a funny anecdote. So we mapped it out, and the surgeon said, okay, well, I'm thinking about, removing tissue in the frontal cortex on the left, and can you figure out whether there's working memory? That was a big thing. That would never be considered for surgical resection because it's only eloquent cortex, and I don't think working memory is part of that. So, okay, we mapped it out, and I told him, well, that's a crucial area for working memory, so I suggest you take that into consideration. So, okay, then don't hear anything, and then I get a call, and he said, well, we did the surgery, it's the day after, and I removed it, but it's amazing, you don't see any deficit. So I said, come over with your laptop. So I go with the laptop, and it's a very simple task, an N-back task, so you just have to remember items 2 steps back, and very simple. And I went there, and I talked to the guy, and he was Polish. He didn't speak Dutch very well, it was a second language. And the surgeon was there, and like always, he told me everything that maybe the patient could have told me. And he said, yeah, and he says, I asked him, are you feeling good? And he said, yes. And then I said, do you remember your breakfast? Did you have white bread? And he said, yes. And did you have it with cheese? Yes. So all that, he said, he's fine. Go ahead and test him. So he sat down in a little cubicle. The guy's really nice and happy. So I put the computer there, and he did the task before in the functional MRI and in the ECOG. And he sits there, and I said, okay, well, I'm going to start the task, and I go and explain the task again, and go ahead. And I switch on the task, and he's like, just sitting there. And I say, switch it off, and I say, okay, let's start again. And, do you understand the instructions? Yes. So I said again. I did that 3 times, and then I realized he doesn't even remember the instructions. So he was very happy, but I don't think he can remember anything short term. So I told the surgeon, he's like, So that was a nice experience.
Sometimes
Not a
these
nice
things
experience.
improve over time for some of the patients. At least there's that. Yeah.
Yeah, I'm sure. And I also remember, I also, I'm aware that for a surgeon, to be constrained too much, it doesn't help your treatment, right? Because you won't be able to remove tissue at all. And I realized around that time the conflict, not conflict, but a kind of a conceptual mismatch that as a neuroscientist, you map out all these functions, you get all these areas that light up, right? And if you tell the surgeon, well, okay, these are all important, he can't do anything. But then you have the surgical reality where removing considerable patches of tissue don't have a noticeable effect on the patient. For instance, with stereo EEG, if you're a neuroscientist and you study fiber tracks, you cannot imagine that a pipe a millimeter, a voxel wide goes through and doesn't have a consequence, let alone 20 of them, right? So that's a huge mismatch between those areas. So we figured, well, in neuroscience, you see everything that's involved, but not necessarily critical. And that's still a mismatch between the two.
Yeah, what's involved with speech and what is essential for speech is, for me, that's always a boundary I have to find, right? Because if let's say there's a tumor, I have to find the border of where things are abnormal, or if it's a seizure onset area, and where function is. And it's you're navigating a contour there that is defined in, basically with all these little separate pieces of information you can get from the MRI, from testing them awake, and with these mapping techniques involved with, from a task perspective, like you're talking about, and then also from stimulation.
Yeah.
And of course, stimulation, you can turn the current up and have it spread quite far, and then you interpret something different is going on.
Yeah. But I guess even stimulation, if you do it intraoperatively to make sure that something is not critical.
Yeah.
Something that turns out critical at that time might not be critical in the long run, because the brain can adjust to losing some of the nodes of the network for language.
Yeah, you have sufficient redundancy to where you do okay. That said, I'll tell you, it's really hard to take something and know that you're going to give somebody a deficit. I don't enjoy that.
No.
And there are sometimes when we have clues that that's okay, and the person will recover just fine. The famous example of this is SMA syndrome, where people generally regain nearly full recovery, but taking that out and giving them a deficit even in the short term is something that we'll do, but only if we have sufficient confidence that that's actually needed to treat their disease and has a high likelihood of doing so. So they're sort of cognitively hard boundaries and then physically hard boundaries, but sometimes there's physically soft boundaries, and trying to find that is always a...
Yeah.
And we use the tools that you developed and our team developed 20 years ago. We use these now with stereo EEG, and they work well.
Yeah.
Yeah. Memory is difficult to test for us for whatever reason.
Long-term memory.
Long and short-term memory as well. We'll have this issue of always trying to decide that the main example of this would be sort of the dominant hippocampus. When can we take that out, especially if it's, let's say it's sclerotic, so it's atrophied some, and you say, well, that can't be involved. There are cases where you then take that and people have deficits, some of which are persistent. And it'd be great if because we do stereo EEG in a lot of these patients, if we had a robust set of tools to look at sufficient conditions for memory and naming.
There used to be the WADA test. Has that survived? I've seen a bunch of those.
It went out of favor and it's come back in favor. So we did the
Okay.
WADA test at Mayo.
Yeah.
But not as many centers do it now as did 25 years ago.
Yeah.
Just because of the catheterization and the injection of the... So what do you know the WADA test is where you basically anesthetize half of the brain and watch for how behavior changes.
Yeah. So you tell people, to remember a couple of items, and then they get injected with this anesthetic, I guess, in one hemisphere, and then they're asked again whether they remember them, and if not, then clearly that part of that hemisphere is important. I've seen a bunch, and they were very interesting events, but it's quite intense.
From the neurology perspective, it's kind of like watching an acute stroke, right?
Right. Yeah.
But for a lot of these folks now, we have other options that are not purely destructive or resective. Neurostimulation for epilepsy has become, it's something that basically every patient can benefit some from. And then what you do is you hope that you can identify a place where resection or destruction of that tissue will give you a cure. If you can't, we have stimulation as a backup. And trying to predict who would benefit from each, I think, is a difficult boundary in the beginning.
There's a lot of work to be done still.
A lot of work to be done. Yeah. So these, you did a working memory experiment for brain-computer interfacing, right? Where you could actually control a computer by engaging working memory networks.
Yes. That basically started a little bit. So I think the first experiment that I did, where I wanted to see whether fMRI would predict, where to put an electrode, is a patient, an epilepsy patient. We had functional MRI while they were doing a working memory, and then ECOG on the same, and we really looked in detail at those signals, and they turned out to be very similar in terms of location. So the fMRI indicated 2 hotspots, and then I compared the fMRI signal during the amplitude of the change with the working memory task to the amplitude of the change in the electrodes that were on top of that, and that gave us quite some confidence. I think it was published in 2007 or so.
Mm-hmm. Yeah, it was
quite the earlier studies where fMRI and ECOG were compared to each other, and I was stunned at how comparable they were. It's a little bit too much detail, but the difficulty, you can charge the working memory system increasingly. You can kind of regulate how hard it is, and you saw that was the high frequency band at the time that we looked at, that where you have done a lot of work on, and we could see that for fMRI the signal would go up longer and higher for more difficult tasks. So the difficult task is like an equation with 3 items, a lot of thinking, versus 1 + 1 = 2. That's very simple. But then for the ECOG in those same locations, you would see that the amplitude didn't go up, but the duration continued. Mm-hmm. And that was really very nice for us because that means that when you activate that area, it doesn't, go haywire. The electricity doesn't go nuts. It just stays on longer. But with the fMRI, where you measure the hemodynamic response, if that area keeps asking for oxygen, it will just increase the signal with fMRI. So that matched really nicely. And then when we moved on to the BCI, we had, of course, we focused on the motor because that's more natural. The motor cortex as a target for electrodes, but we had the working memory area covered also because we trusted that people would be able to, control something by engaging their working memory. It's not intuitive, but we felt very comfortable that would be a backup.
So what would have been the patient's task then to activate
Count
the BCI?
backwards.
Okay.
Yeah. So we did multiple experiments in ECOG also, where and that was more for research. We asked the person to count backwards in 3s or 7s, depending on their capability. And we did really nice experiments where we stimulated briefly for 5 seconds. The neurologist would stimulate the target electrode. People would count backwards in 3s, and then during the stimulation, they would stop and then would start again at a completely different number. And we would ask them, "Hey, what's that?" And he said, "What's the problem?" That was really straight. So we really eliminate that brief moment of memory and just cast it out. They picked up afterwards, but not necessarily exact the same spot, and they were not aware that they lost a little bit of information.
So you could measure that load. I do wonder whether, and maybe you could tell us a little bit about this, the fact that the places that would normally control the body, when they lose the ability to control the body, the normal feedback that those areas of the brain get and the normal reinforcement that helps maintain the structure, the computational structure of those areas, when that's lost, some of these areas degrade. Do you think that there should be more of an emphasis on the areas that we know remain more intact because we assume these people have rich internal worlds, and exploring the representation of those worlds and getting feedback based upon it? Or do you think that trying to keep that intuitive mapping of the loss function is better, or should it always be a combination of both?
Well, I think there's different considerations that contribute to this idea, right? So for us, the most important is that when you go to BCI and a person wants to control something by brain activity, it needs to be, or preferably it's a logical thing to do. That counting backwards, what I just said, our participants did that, but it's not natural. So it takes a lot of effort, and a lot of effort is one of the enemies of BCI when you want to make it work at home, right? Because people will stop using it. That's the biggest risk that you have with any activity in the BCI. So then you look at the motor system, which is much more natural. You just try to grab something, right, and that will activate it. And you're saying there's no feedback, so we don't know if that's the optimal area to target. And we still don't know if it's the optimal area to target because we find some strange things in people who've been paralyzed for a while. So, but it's, intuitive operation is by far the best. Now we may get there in the conversation, but we've had candidates where we implanted a BCI system on the motor cortex, and they really didn't do very well in generating activity there. And whether that's because the feedback loop has got lost or whether there's another reason, we don't know. So we did have the backup electrodes on the working memory area, which, it doesn't need physical feedback. It's an associative cortex. Eyes and ears is perfect to reinforce whatever happens in there. Well, the motor cortex needs sensory feedback because that's how it's built. And that also stopped working or we think it stopped working, and there's reasons that we don't know 100% sure, in the patient. So when you talk about, having the system work properly, or trying to make a system work in a paralyzed person with a BCI, I still think that the motor cortex is by far the best target.
Okay. Can you tell us a little bit how you went from doing brain-computer interfaces with epilepsy patients in the hospital where they're controlling cursors on screens at the bedside to a fully implanted system? And I think you had the first fully implanted system. Can you tell us about that trend? What was sort of what was the transition, and how did you go from one to the other?
Yeah, well, first of all, we should give credit to Phil Kennedy, who
Absolutely.
was the first to have a fully implanted system. So,
Yeah.
credits all there.
As we should. We've had him visit here.
Oh yeah,
We flew him up to talk with us, and he's lived a very interesting life, and
Yeah.
he's certainly contributed a lot. Really fun guy, though.
yeah.
Yeah.
Our world is full of interesting people, I think. So,
Yeah.
but yeah, how did it go about? So I told you we were doing the ECOG, and we're getting more comfortable with it, getting more patient. The clinic was getting a little bit more comfortable with us. We found a balance, so we could expand the program a little bit. And it's very, resource intensive. So 2003, 2004, I got more interested in BCI, got involved in the BCI meetings organized by the group of John Wolpaw, mainly EEG at the time. So they had meetings every 3 years or so, and I have no particular affinity with EEG, and having ECOG, you're like, okay, well that's the only way to go, ECOG. So we started figuring out whether people can actually control the system with feedback, and the typical task was the Pong task. We did that a lot, or we tried some other things. So if you want to, with in mind that we're going to go towards an implantable system, right? And there was just no idea how we would get an implantable device and everything. But if you do the research, you just tread along, and you see what happens. I definitely did not have a wish to go into the single cell recordings. This is not my background, and it's a different family, different science. I was much from the ECOG and the topography background. It's a very different approach. So we started doing experiments with the Pong task and get people to control it either with their hand, or we tried it with the tongue, and wherever the grid was, and the results were good. Mm-hmm. And of course, people, when they move, they get a lot of information, feedback, sensory feedback, which is cheating if you're going to go for people who are paralyzed. So we also asked people to imagine things, and then we did fMRI studies, just working all up, and I was quite disappointed with imagining movement in healthy volunteers, whether that would predict attempted movement in people who are paralyzed. Mm-hmm. And I don't think it's the same. And actually, Dora Hermes did the first work that convinced me that, if you want to do research in healthy people that informs you about what to do with BCI and paralyzed people, you better have those people just move. Because if I ask you to imagine attempt a movement to generate activity in the motor cortex, but you're not allowed to execute it, your brain is full of systems to block it somewhere, maybe even before the motor cortex.
I mean, we did get it to work in Seattle pretty well with imagery. Yeah. So you mentioned Dora Hermes. She was your graduate student. And if I remember, she was pretty good, and then she abruptly left the lab in 2010.
Yeah, I'm blanking out there. It's like, you really want to go into this?
You did introduce me to my wife. So.
Yes, you did. So for those that are interested, Kai gladly swung in, when was it, 2007 you visited?
I visited in 2007, and you invited me back for a summer in 2008.
Yes, but there was some magnetism going on outside of the magnet between Kai and Dora, who was a graduate student at the time, and that was, I think, a very quick, how do you say that, evolution. They gravitated towards each other really fast, and it's a blur to me, because I think from that moment on, it was clear that Dora was going to be supervised remotely at some point. We went through different cycles. She was supposed to come back, and she said, no, it's something is making it impossible to come back. And anyway.
And that something is, I think, off for a run right now, back across countries.
Yeah.
But, I
think it worked out really well. I mean,
certainly for her and for me, and I think for you as well. But I think that role that you had for her as a mentor, both understanding, and I got to see this kind of by proxy, right? Because I was her partner throughout the process. But I thought the way that you insisted that she hold to certain standards and have a certain amount of rigor, was very good, but also the degree to which you let her be herself scientifically, and then also you let her be herself interpersonally, right? She spent the second half of her PhD
Yeah.
in America. So, I personally want to thank you for that. But also I think that being a mentor, particularly sometimes with people with females, having mentors who are understanding of the different role, the different maternal role, and accommodate that and support people through it. I mean, she's done amazing scientific work ever since then, but I think that the fact that you are so supportive of her is something that she's grateful for, I'm grateful for, and I think you should be very proud of. I mean, I know that you've had many women that you've mentored, and that's pretty cool. So,
Well, thank
anyway,
you.
yeah.
I'll continue to do it then.
Wow.
But I have to say, Dora also had a mind of her own, and I recognized pretty quickly that whatever was going on between the two was not something that was going to be amenable to any any attempt to modify by me. So, but yeah, it worked out fine. Yeah, it's good. So I forgot the question.
So you were doing electrocorticography in the epilepsy monitoring unit, and at some point you moved from epilepsy patients learning to control these devices, in basically tens of minutes at the bedside to people who are implanted for life, giving them functionality that they've lost. And of course, those are two very, very different contexts, but you bridged it well on the first shot, right?
Yeah.
So right from the beginning, you got it to work.
Yeah, I think I didn't progress from one to the other because the ECOG research kept on going until today. Actually, we still do ECOG, but the stereo EEG. But it's becoming less and less attractive in the sense that you only have like a limited amount of time with an epilepsy patient. While you'd be much better off if you have chronic, a lot of time with people that are planted permanently. So it happened. It all gets propelled by grants. So you have a claim, you have a grant, and then you have some funding. So I got a grant to work up towards an implant. I had no device and anything, and I was as ignorant as possible. I figured, well, I will find something and we'll put it in, not being held back by any intelligent knowledge about regulatory and safety and stuff. So I wanted to have a advisor, scientific advisor. So I found out Medtronic had the Bakken Research Center, and I called out, and I emailed, and then I got an email back from the CEO at the time, Keith Mullett, and he said, "Well, hey, this is interesting." I told him BCI, and he said, "But I'm close to retirement. But why don't you come to this meeting that we have in Switzerland?" In Tolichinaz, where Medtronic at the time got all the scientists that they work with together and gave talks and everything. So I showed up there, and they gave me some time to give a talk about BCI. And after the talk, someone comes up to me and he said, "Hey, let's talk because we may have some mutual interest." And that was Tim Dennison.
Yeah, he's been interviewed right where you're sitting now on this show.
And we started to chat, and he explained about his work on the DBS device, that they wanted to enrich it with sensing, and that maybe the sensing would be good for me. So that looked very interesting, but we still didn't have a plan to implant a person. But as we went along, and it was a very rocky road mainly for Tim, because the idea was that they would get an amplifier that would sense whether stimulation is necessary for Parkinson, and the academic world had said, well, the beta power is your biomarker, but it turned out that's not always the case. So what do you think? At the
Not
time,
always, for sure.
Well, he's doing this now, so we have patients
How
who are
does it work
implanted.
out for you?
Yeah, so they just released the adaptive sort of, I mean, the sensing's been out for quite a while, but they just released the adaptive algorithm, so you can actually use it now.
Right.
As originally intended. And it really depends on lead location, and it depends on the patient, but we're having some luck with certain patients, yeah.
Okay.
Yeah, but it's not always, but then to your point, so beta frequency oscillations probably aren't the best marker for tremor, for example, or if you have a patient where dyskinesia is a big problem in certain conditions, it may not be for that particular patient the best thing to track.
Yeah.
But at least it's something. It's exciting to have something now.
I think that's what played around,
Yeah.
and then Medtronic being a big company with very different forces at play. Every now and again, Tim would reach out and say, "Hey, do you have data?" But because he gave us the radio in a box or something, it's basically electronics.
A benchtop version.
Yeah, exactly. And then we could hook it up. We could do that, and so we would send him some data. We were interested in high frequency band. He was interested in the beta band. So it was like a mutually beneficial collaboration. And then we started to talk about an implant for an ALS. And in 2005, right after we got a bigger grant, I started to get some people for this crazy plan which is well before we met Tim. We sat down and we did like a SWOT analysis of the group of 5 people about what kind of BCI do we want to make. And the paper had come out, or we knew about the work of the BrainGate, and we're like, okay, are we going to go for the degree of freedom path, where the BrainGate wanted to add degrees of freedom, the richness, the width of the information you can get out of the brain. And we said, no, let's focus. Let's try to prove that BCI can actually do something that cannot be done in any other way. So we ended up with targeting people with locked-in state. And the most logical would be either brainstem or ALS, because they're the most frequent ones. And then use whatever signal we could get to simply make it click, because our big worry was that if you want to prove to the world that this is a benefit to a person with disabilities, it will have to work at home. That's the single and only proof, because any assistive technology and any assistive device, there's tons of them. If people somehow don't like them, they'll stop using them. They'll abandon the device. But with an implant, we didn't want to risk that. So we said, okay, we want it to work 99% of the time, and when they want it and if they want it. So we decided to go for a click. Use all whatever channels we could get just for a click. And then that brought us with Tim in a comfortable situation, because there was only 4 amplifiers that he had in there. And then jumping forward a little bit, we went back and forth, and then we applied
That was the
for
RC plus S device.
the PC plus S.
Okay, PC plus S device. Okay.
Yeah, and it took us 2 years to get approval, because it was not CE marked for the purpose. It was complicated. It was not CE marked. So, and also not necessarily on
CE
label.
is the European version of the FDA.
Yeah, the FDA clearance. So we had to convince the hospital and the ethics committee that this was a good thing to do, and that took us 2 years, because they had never had that kind of request. They would only allow research with approved equipment and implants. And so it took us a long learning process. We teaching them about what we learned from Medtronic about the paperwork for safety, proof of safety and things. Anyway, and then we got approval in, I think, 2013, end of 2013, and then you can start recruiting, and then fairly quickly we got in contact with the first candidate. We had to, actually it was a lot of work to get the call out that we were looking for a candidate, because people with ALS, they are no longer in treatment. So there is no neurologist that says, hey, I have all these people that I can contact, because once they're in a very late stage, they go into rehabilitation realm, and pretty soon they're only being helped by therapists and things. So you don't really have a network that you can go through to find them. So we did a tremendous amount of work to get the news out. And then we got the first candidate. She was great. And then we implanted in 2015.
Yeah.
And that was over motor cortex then, or?
Yeah.
And you were looking at what, 80 to 100 hertz, or because the sampling frequency is only 250 on that, right?
Yes.
So you're limited
200 actually, I think,
200,
at the time. I still admire the design of that device. So it has a permanent battery.
Yeah.
So you have to take care that you don't deplete the battery, because a reimplant is just horrible. So we got the device. It had 2 modes. One is streaming data.
Sure.
And the highest cost. I understand the electronics. I know there's choppers in there, and apparently that's a very, efficient way of converting raw data into power. So Tim come up with two modes. One is streaming data, 200 samples per second, which depletes the battery within 30 days, right? They modeled it 30 days. And we wanted it to work for 24 hours a day. And the other was that if we would indicate what kind of bandwidth we would like to have from each pair of electrodes. So that would give us 2 data streams, or 4, I forget. And you'd ask, no, 3, sorry, it was a complicated device. So it would spit out every 400 milliseconds the power in bandwidth for particular pairs of electrodes. So we figured all that out. So we had the first patient, all the patients, we had the leads come out for 2 days after the electrodes were placed on the areas that we identified with functional MRI. Then we would hook up all those, we would put 16 electrodes in, hook them all up to regular equipment, and then try to figure out what the most informative electrodes would be. And we could connect to the device only 8 electrodes. And then a second surgery, and then the device would be implanted under the skin of the chest, and the leads would be tunneled under the skin and hooked up. So 2 were not hooked up, and 2, I call it grids, were not hooked up, the 2 were hooked up. So, and then that was what we would work with.
You were talking about the general capabilities, the system, what your strategy was.
Yes.
You were using power and band on a specific range from 2 of the 4 strips that you implanted.
We found high frequency band, and we wanted 65 to 95, but because it's an analog amplifier, we didn't quite know what the bandwidth in the center would be. So we found it out, let's say somewhere between 50 and 100, roughly, and we played around a little bit. But we also went for lower frequencies because the decrease in alpha/beta is, based on EEG, it's the most robust signal to get. So we played around with both.
Yeah. Okay.
And then we ended up finding after a couple of weeks or even a couple of months, because it took us a long time to get all our act together. Once you have a patient, you realize that a lot of stuff is just not organized well enough. We decided to subtract one from the other.
Okay. Yeah. That makes sense. Yeah. And then the processing was all done sort of externally. The device would stream off, and then how did you sort of implement the finals? How'd you use the click, or the patients, how'd they use the click? Were you able to integrate that in useful devices or things?
Yeah. The one thing I forgot to tell is this ability of the device to spit out power data.
Yeah.
So that would only spit out a few numbers every 400 milliseconds or so.
Okay.
That allowed the battery to last for 5 years.
Okay.
24/7.
Quite a difference, yeah.
Quite a difference. So all the experiments we did, we would switch on the streaming for as short a period of time as possible. That gives you the full bandwidth. And then switch it back to time, to the frequency split. Mm-hmm. We first played around with Pong game. Mm-hmm. She loved the Pong game until the very last day that she used it. She loved the Pong game. And then we were going to gear towards a click. Mm-hmm. So we developed tasks where she would train to click at the right time. That turns out to be most difficult for people in this kind of late stage ALS. And so you would have a bar, you would have a point in the middle of the screen, and you would have a bar move from left to right, and she would have to click when the bar was at the level of the point in the middle. And then once she kind of got the hang of that, she was pretty good. Participants after that had a lot more trouble with this. So we discovered that the timing of a click was very difficult for them. Timing to generate an intent that would increase the power in the signal under the electrode. And after that, we started playing with spelling. So we had a simple program for spelling, but pretty quickly we realized that if we wanted to make it work for her at home, our software was not going to pull it, not going to do it. So we switched to her Toby.
Okay.
So we bought the
You got
software.
back-end control into Kobe?
Yeah. So we had we would emulate key presses. Mm-hmm. And feed that into Toby, and she could use her eye tracker, Tobii software to do it, and that was a very good decision because she could organize the screens the way that she liked. And or well, we would do it, but she would ask, okay, you want to have these chunks of letters. It's all scanning software, line scanning, and that with that simple click that now was trained, and we built what kind of a digital filter box. I won't spare you the details, but it was not straightforward at all because it's not like click, not a switch in her brain. The signal is still very, very noisy, so to say. But we found a decoder that would get it like 95% correct. So, and the number of false positives versus the false negatives, that was a balance we had to find. And we worked with her for, I think, 3 years intensively, and then we toned it down a little bit. After 6 months, she had a click at home. So we built software on a tablet for her to use that would always work, and you know it was very super robust but very simple. And with that, she could call the caregiver. We called it an alarm bell in the beginning. We got rid of that real quick because people get. The ethics committee gets very nervous when you say that. So if you call caregiver button, that allowed her to, whatever she was doing, whether it was a game or in Tobii, she would have all her icons. Like she could click on one button that says, well, please clear my throat for the caregivers. But she could jump right out, and there was a special menu where she could either go back or she could click on call the caregiver, and it had a little alarm, and then they would come.
So all these things that you're describing, and Brian, just so you know, there's this paper that we wrote several months ago. I've been trying to get Dr. Ramsey to read it for the last few days.
I've never heard of it, and he doesn't.
All of these things that you're talking about, I think, for me, sort of epitomize what the right way to do this is. First of all, you're taking somebody who's disabled and you're giving them function that replaces it. You're giving them a function that replaces their lost function. Whereas a lot of the brain-computer interface studies that have been done, they're taking people who are disabled, but they don't have any use of that device when they're not participating in experiments. So it's not really a therapy, it's a way to make it so they can participate in experiments. But for you, from the start, the person's using it at home. They are back-ending into existing software that's out there, that's intuitive for them, intuitive for their caregiver, intuitive for the rehabilitation team that they work with. I think that these are all very patient-focused, appropriate ways to do brain-computer interface research, and this is not the norm in the implanted community. This has not been the norm.
Yeah, we talk about this a lot, but I'd like to nuance a little bit in the sense that we decided to go out there and prove that a BCI could actually add something to a person's life more than just fun or so. So we worked with people that are most severely paralyzed. Most of the people we look at are already on mechanical ventilation. So to give them a click, the benefit there is huge, because the alternative is that they cannot communicate anything until someone comes with a letter card and you blink when they point at a particular letter, which is very, it's not nice because you cannot express things that yourself. You can't control software by yourself. So our first patient liked to, choose TV programs or read a book or something. She had some autonomy there, versus if you don't have no autonomy. So it's kind of easy for us to make a difference, provided, of course, that it's good enough for her to be able to want to use it, that it's reliable enough. Now, if you look at the next stage where you're thinking, okay, let's see if we can help people who are paralyzed from the neck down, they already have a lot of functionality, right? So if you have like a spinal cord lesion,
it's a high bar.
You can do a lot of things. And the idea is that if you have a BCI and you actually want to make it worthwhile, it's going to have to beat what non-invasive assistive technology is already there. So the bar is very high there. So as you go further and further, you're going to have to do much more sophisticated functionalities. And I think that's kind of the stage, we're getting at. because I think the people that are severely paralyzed are still not served, right? So they're kind of, I would like to focus on that, even if a click is the same. And Synchron is really trying to fill that gap, right? So it's so they're working on it, but we're not that. It's not a therapy that everybody can enjoy yet.
So
And
you
we
see
don't have to
Synchron-
wait. We don't have to wait until you can do speech decoding. They can benefit from a click if you know that the alternative is just, being completely dependent on other people.
And you see them as a commercial continuation of the same patient-centered focus, where you're not taking disabled people and making them participants, you're treating the patient themselves.
Yeah.
Do you think Synchron really embodies this same approach that you had, where it's patient-centered from the start?
Yeah, I like to think so. And I
Yeah.
mean, I don't know all the details of how they work, but everything that we do with their interaction. So Mariska van Steensel, she's my kind of right hand in the group. She communicates a lot with Synchron and different entities in the U.S. that are working on trying to figure out how you determine that a BCI provides a benefit to the end user. So outcome measures, clinical outcome measures. And what everything I hear and see and feel when I talk to people from Synchron, and it is they're really trying to fill all the gaps and connect all the dots to make it work for people that are severely paralyzed. So very, very much in line with what we're doing. It's just that they're much more successful in getting things on the rails in terms of a commercial company.
They have a large number of resources they've been invested in, and that's
And they've
That's good
done an
that
amazing
this
job
is-
so
yeah.
far. Yeah.
that's great.
Yeah. So, but the next stage is, having to come up with decoding performance and richness that will compete with an eye tracker. That's already going to be a huge challenge.
Yeah.
But if you're at the level, you don't have to be better than it. If you're at a level, an implant is always more convenient because you don't need someone else to set things up. And
You give them a degree of autonomy.
Yeah.
And autonomy and dignity are closely
Yeah.
linked.
Yeah.
Absolutely.
Yeah. So I do appreciate the objective of decoding speech, because that clearly it fulfills a lot of roles. But I think what's been achieved with speech decoding now in people that they're severely paralyzed, but not as severely as the ones that we've worked with, because our people can't speak, may not be predictive of whether it's going to work in people that are very severely paralyzed. And that's because we found out that the ability to generate a click at will is not straightforward. We had one patient that took 6 seconds to generate a click, one that took 8 seconds to generate a click, and we had no idea why. It's just you have to wait until this wavering signal exceeds a threshold long enough. And with the first participant, she would just generate the click. And and that's what you would expect from any healthy person. But what determines that the speed of generating an intent that you can decode, we have no idea. So that's still a lot of work that needs to be done. That's not necessarily history now that there's companies with advanced systems coming up. The problem is out there. It's not with the engineering part. It's with your target population. Do we understand them well enough? We don't know. And you need the trick is you need to provide them with an implant to be able to look at the signal, because the outside of that you just don't measure the kind of signal that you get with the electrodes implanted.
Sure.
So we're at a kind of crossroads at this point, I think.
What do you think the central principles are that you've learned that will carry through to larger brain-computer interface permanently for, let's say, for ALS patients?
Yeah, guiding principle. The world has become very complicated now. There's additional stakeholders, right? Companies and investors and everything. What we've felt very good with is that we had the dual purpose, the dual goal with participants. Is one, that we said we were going to develop technologies that you may not benefit from, but at the same time we will give you technologies that we've developed for that to use by yourself, independent from us. So people immediately have a home use of a system that might not be top of the line and everything, and they spend 2 days a week working with us to provide data because they have to do tasks, especially people on ventilator in the late stage. They spend a lot of time on care, right? There's a lot of things that are going on, so we could maybe engage them for 3 hours a day. That sounds a lot. But they get tired very easily. Things need to be reset. The caregiver comes in and something needs to be done. So in the end, you maybe have like an hour and a half of usable data.
Yeah, but your patients were using it without you there.
At home.
Yeah.
Yes, but we don't have access to those data. And we learned from
I
the
see.
first,
Yeah, the data that you
the
can
first
learn from, sure.
participant, Hanneke. We negotiated with her, right? And we said, okay, we're gonna give you this tablet with the software, and you can use it at home. And but we can, we would like to have the data. And we said, but we were honest. We said, we know the whole system, so from the data we can reconstruct what you were spelling. And she said, oh no, I don't think so.
No.
So we built in 3 levels of logging. The most open level was including all the raw data and everything that we could use to debug the system if necessary. And then there was an intermediate level, and there was the privacy level. Mm-hmm. And the privacy level, we would only collect very basic information and not the data and not the markers or the labels or anything. Mm-hmm. And they created log files with a start and an end time. Mm-hmm. And we would have access to all the log files that were pretty empty. And that gave us a clear idea of how many hours per day she would use it. Mm-hmm. And that's how we know exactly how long she was using it, how intensively she was. But we have 0 data to use. And we were quite fine with it because that was really her system. So, and so you have to get the data from research.
I think that it's really nice to be able to see what you've provided to patients and how you took sort of the basic work that was done with these epilepsy patients in short, brief stays in the hospital and translated this into something that helped these patients that have ALS or that had high brainstem stroke. And I think that it may be looked back on as the most ethical implementation of brain-computer interfacing and the one that was done with helping people in mind the most. And I think that what it's told us and others that want to build devices that are patient-centered is it's given a framework that we can then work from. And I'm very grateful to have that. I mean, I'm also grateful because I've known you and you've been a friend and mentor for a very long time.
So, I think I appreciate being asked to sit here. I enjoyed talking about this. That might be pretty clear.
Yeah.
I think they're very exciting times moving forward in this space and for people to try to figure it out. And I think the concept of driving the BCI home, literally having BCI at home, I think that's something that we've been, as a group, we've been advocating for since the very beginning, and it seems to be something that the companies are very aware of, and I hope that they're going to be able to pull that off. But again, I think it's going to be easier if you work with most severe participants for synchron. Well, easy is not easy, but if you want to make it work at home for people who are less severely paralyzed, it's going to be a tough call.
There's a very high bar there. Yeah. And I think one thing, a discussion that I've had with people in the field who've implanted devices for brain-computer interfaces with people who have, with disabled people, is I do think that the benefit that patients have can't be closely linked to the attention and the joy that they get out of the experimental sessions to learn the science. And I think that needs to not be conflated, and has been. So I'm glad that you articulate the difference between that, because I feel like the justification has to always be in doing this for a person who is a patient. Yeah. And if you have somebody with let's say a reasonably high cervical injury, but let's say they're C5, they can talk. Yeah. And I don't mean to say that they're defined by having a C5 injury, but they can speak. You can decode facial animation to do all kinds of things. And the bar there to be implanting them with a device that has risks of significant morbidity and permanent injury should come with some clinical benefit that they're going to get, clinical benefit.
Yeah.
So they should be patients. It shouldn't be disabled people who are calling patients, but they're actually just participants in the experiment.
Yeah, I agree with that. But I think for people who have spinal cord lesion pretty high up and they can talk, we are setting up studies to include them for the implants because they would very much, what we get from patients and caregivers, they would very much like to be able to independently control devices that everybody else can. It's like swiping a phone or something like that. And, there's people think, well, actually, in the first years when we were talking about this, we had this big meeting at the Medical Center of all the brain-related disciplines, and there were like 30 people sitting there. We were saying, well, we're going to build a click for a locked-in patient. And one of the surgeons sat up and he said, well, what's the point? They can move their eyes, so what else do you need? And then I realized that there's a strange perception that we all, us, and this is something that Jose Milan, at the time it was in Switzerland, very nicely said. It's like, we all enjoy choices, right? And we feel very constrained if we cannot make a choice, for instance, in what kind of car you want. Let's say I'm going to tell you, you can only buy this kind of car. You're like, really? It's not going to happen. But then you have a person with disability that has almost no choice, and then the blink of an eye is good enough. So, but then back to someone with a high spinal cord lesion, people say, well, yeah, they can speak. It's good enough. No. They would like to have a choice. They should have a choice. So if they want to choose for a device that's implantable that allows them to do things that they want to do, I think that's what humanity is about, right? Giving people equal choice.
But I think that the functionality that you have to provide to them has to be good. And it has to be their device that they use, not somebody else's device that's put in their head so they can participate in experiments.
No, it needs to be the device that has a good reliability in terms of providing
open use
the participant with what you claim you're going to provide them with.
Yeah.
And there's still a long way, because if I'm a manufacturer of devices and I'm assuming that it's going to work for healthy people, or assuming that it's going to work for all people with disabilities at the same time, they're going to have a hard time moving forward, because they're going to encounter a lot of people where for some reason it doesn't work, and you're going to have to resolve that, because your product needs to be, it needs to be reliable for everyone that gets it. So there's still a hurdle to get, but I totally agree. It has to be something that person chooses as an addition to their, or the assistive technology of their choice, and it should work.
Yeah. I have maybe a couple other questions, but
Yeah.
anything in particular you want to ask him?
Yeah. Well, I was reading a little bit about that you either have started a company or you were looking into a company to automate reading of. It's a little bit off topic, but
Yeah, no, it's a very good point. So,
of fMRI data.
the fMRI company.
Yeah.
Oh, well, that was good. So I figured it doesn't exist anymore, but we had.
Okay. I didn't know that. Yeah. I just read a little bit about it.
But so we did functional MRI, like I told, for the patients for neurosurgery, and we realized that there's no research to be done with it. So we made it kind of a smooth clinical routine, and at some point I figured, well, if it's so routine, why not see if we can spin off a company? So we got some funds for that, and we rewrote the whole code in a company structure, and I learned everything about regulatory, because it's a medical device. Software is a medical device. Class 2A, because the surgeon may make decisions based on the information, which is a high class, very strict. So we got ISO certification for that company. We got the clinical fMRI software, which would be autonomous. A clinician would have a CD play the task to the patient in the scanner. The data would come in DICOM. They would just upload it to their server in the hospital, it was safe, and then out would come a report for the clinician, for the neurologist. All really nice and fine, and we got CE mark for that, for a second version before we sold a single product. And that's okay, and it was all very tight. The investments were very, scroogey. It was very difficult to get funding to get people to go out and sell it to the hospitals. And then I managed to free some time. I was going to travel around Europe and do things, and then that month, COVID hit. And the hospital was like, "You're not coming here." So, and then it just dried up, and we just folded the company before we got big debts and that. But we learned an incredible amount we learned a lot about regulatory. It makes it so much easier to work together with the companies that we work now with for the following implants, the brain implants. I understand where they come from, so it makes it easier, to keep them attached to the purpose, because we want them to start commercializing their implants. So, and there's 2 companies in Europe that we work with.
So in the spirit of this, there's a few things I'd like to ask you about what companies owe to the scientists and the participants in these studies. I mean, I think, for example, the devices that you implanted patients with, the Medtronic devices, they discontinued that hardware, and they haven't opened up the APIs to be able to use this with their current devices. They may, and I think that their hands are tied from a regulatory perspective from certain things. But I do wonder about, should there be interoperability standards so that, for example, the Synchron device should make adapters that the tails of the Medtronic leads that are in place can click into? Should there be standards that are set, just like we have USB standards for computers, for device interoperability? It gets difficult, I know, for the single unit type things, or where you have 1,000 channels, but where you're dealing with, let's say, 32 to 64 channels, you can have 8-channel pigtails or 16-channel pigtails.
Yeah, that standard's definitely not there yet.
Do you think the time is here to where we can make some of them? We can define classes within certain channel counts. There should be interoperability defined by these form factors.
I know that there's quite some activities at IEEE level and even EN level to get these standards.
Yeah.
But I haven't heard any interaction with companies that much, the relevant companies. I think so basically the underlying problem is, if you have a system and it's either discontinued by the company fails or something, you would like to replace the active part, right? When the battery runs out or breaks or something. But you don't want to remove and replace the electrodes because they're encapsulated in the skull and everything. So those you really would like to. So the only solution there, the easiest solution would be to have a connector. So if your company build a device, you typically will bond the leads of the electrodes to the device, so it's one unit.
Right? So I'm very strongly of the opinion that there should be connectors. Yes. And with CoreTech, we asked them to make connectors, and we happen to be using the Boston Scientific connector schema with CoreTech. CoreTech is our, well, I mean, we're in a lab together, but for those that are listening, CoreTech has a 32-channel sense and stim device. Right. Dr. Ramsey uses it. Dr. Clausen and I use it in the testing phase. We haven't implanted patients with it yet, but we have preclinical testing of other kinds going on. Having modularity is always important, I think, because even if you have let's say you have a perfect device that's going to be supported forever, if a component breaks, you want to be able to swap out that component, right? It's like the Bullfrog hot tub we were talking about. You can take out, it has a unified system. So if one thing breaks, you just take out the chair seat and you put a new one in, and you can fix it in 20 minutes.
But I think there are no connectors yet for more than 8 contacts or something. You need new connectors. I would very much favor the development of that, because that's going to be
maybe some ribbon-based system for the high channel So a ribbon-based connector schema for high channel
apparently
devices.
the connectors are the most difficult to make.
Yeah.
So
Engineers are always complaining about connectors.
yes.
Do you think there's enough incentive for the companies to kind of move toward a unified standard, or are they going to
No,
require a lot of pressure?
think it's not on their written now because
it
they
just
have
seems like-
other
Seems like
challenges.
that's maybe their advantage to.
Yeah, I get
do
the impression that they're incentivized for the exact opposite, right? So the current DBS systems don't have interchangeable connectors. You have to use,
Right.
you have to have adapters for them, and I think it.
But at least it's possible.
Yeah.
Right.
I mean, there are a couple of things that I'd like to bring up sort of directly related to what you just said. So the idea that you have strip electrodes that get encapsulated, some of these studies that go on with commercial devices or otherwise, in the study design, people will put in planned explants. And the degree of invasiveness for a planned explant of a BCI device is significantly more invasive than the implant. And I think there needs to be complete transparency about that, both to the public and also to the patients. And I think that there needs to be more appreciation from the review committees who decide when devices go in and who they go into, about the fact that if they want a planned explant, because certain people like the idea, oh, it's just temporary. But the truth is that the planned explant is significantly more invasive. If you show people pictures of an implant and it's I can get strips of arbitrary dimensions in through a burr hole of this size.
Yeah.
Taking those out 2 years later is going to involve not an incision that's, that's 3 to 4 centimeters in a burr hole. It's going to involve basically an incision that's a quarter of the size of this whole scalp, just to uncover where those leads are and be able to take them out safely. Yeah. And I think that the idea that you have planned endpoints for explant is something that is now that's presented as a good idea and a feature in some of the folks that we talked to. And I think there needs to be an understanding, and I don't know what your experience is with this, that the morbidity of taking devices out is often significantly higher than the morbidity of putting them in.
Yeah, I have a couple of ideas. So when we started with the first ethics protocol, there was the ethics committee there was no way that they would discuss a planned explant. They said once the people have it and there's a benefit to the device in terms of communication, it's morally impossible to take it out. And we were very much in line with that.
Absolutely.
So there was no discussion
Yeah.
there. So we knew that it would stay in for as much. And now you have multiple studies that in the process. One we're working with Ability Neuro, one with Cortec, to implant their devices. And the ethics committees, there's no question about a planned explant. So, but we do have, when a study ends because either the participant doesn't want to continue or it doesn't work anymore, or we have a reason to do it, there's a choice of several levels. And one is just to leave the system in place because it's safe. It was safe in the beginning, it's safe for chronic use. Or you take out components, like you can take out the amplifier, leave the leads, or you can go all the way up to the skull, or you open it up and take it out. But that's only formally there, so people have the right to have it taken out, but surgically it doesn't make any sense to go into the skull.
So devices that I put in the brain, we do not, unless there's a specific reason why you have to take it out of the brain, you will generally keep the hardware in place. Whether it's an electrode lead or a shunt, which is just a tube, you don't want to mess with it unless you have to.
Think of that, whatever you leave behind under the skull needs to be passive, right?
Yes.
If it's an active component, there's always a bit of a risk, I guess, but I'm not 100% sure. But I would feel more comfortable if any electronics are not under the skull, but I don't know.
I haven't given a lot of thought to that yet, actually.
No, but it is kind of vague, right? The devices that we worked in, well, the Medtronic device is a titanium can. And it's been proven to be robust and everything. I would trust it just fine. But anything experimental where you don't know whether the insulation is going to last a long time, I don't know.
Yeah.
But temporary implant, it will happen for companies to prove. I think for Neuralink they have a temporal, a timed implant explant simply for
It's a number of the different companies.
validation.
It's other companies that we discussed actually also.
So how many of the implanted patients had ALS versus like maybe a high cervical lesion?
Worldwide or in my
Just in your program? Or
yeah, so we implanted 4 people, of which 3 had ALS.
Okay.
and the spinal cord, and they all had challenges. The first one was the best. Super motivated. She was a medical doctor before she she was diagnosed with ALS. The one with brainstem stroke, she had a very unstable brain signal because of the brainstem, so the beta oscillations were all over the place, and as a consequence, probably the high frequency band. And one just was declining too fast. It was like from pretty good to completely locked in within 2 years, 2.5 years. And then we had one that we had, but then family circumstances changed, and she discontinued after 3 months.
This is a small sample. So I was kind of wondering, because in ALS, of course, you have the lower motor neuron, but the motor cortex itself is affected, and I don't know if that changed the signals over time in the advanced cases. But it sounds like
we don't know yet.
Hard to know.
But my big desire now is to be able to get funding for a large study with 100 participants.
Yeah. Okay.
Across different indications like brainstem stroke, spinal cord lesion, or stroke, ALS, CP. We're very interested in getting CP done, and multiple sclerosis. And I had engaged like 15 centers in Europe to do the surgeries and do the recruitment, because they have to be nearby. And then see how, what kind of benefit we can offer with the BCI system. So it is pretty, but also to figure out what are the indicators that preclude successful use of a BCI.
Yeah.
Because I think, the timing of the intent, the short window that you have in people with a rapid progression of ALS or another disease, those are things we need to know.
Yeah.
So that we can position it properly, and that you can actually get reimbursed, and the regulatory, all that. So like a seminal, I actually call it a technology user needs alignment study. TUNA for short. I like it. The TUNA study. Okay. But and that doesn't exist in any other. I like it.
Fair enough.
I hereby coined the term TUNA study. Anyway, but we don't have that in other ways, right? Because all the outcome measures of all the neurotechnologies, the DBS and everything, it's a single measure, reduction of tremors or something, single measure. And BCI, it just doesn't exist. So you have to approach it very differently. It's like a plethora of solutions that you can offer to a plethora of candidates, but you just don't know the need space that you need to fulfill. You don't know what precludes a successful use. And companies are not going to find out. They're just not going to report on the participants where it fails.
Do you think there should be requisite data sharing from companies the time they implant, in the same way that there should be for anyone who has, requisite electrophysiologic data? Because a big gripe that I have about brain-computer interfacing is that, I've been doing it, research related to it at least for 20 years, is that the focus seems to be on demonstrations of capability over and over and over and over, but without general principles for the science that underlies decoding of brain signals, how the brain responds to feedback, and how the signals that we measure scale, right? And this is something that I think is important to work on. But if it now makes the transition into, let's say, the commercial space, you don't always get the data that you would need in order to make that scientific progress from industry. In fact, if you get certain kinds of data that could reveal a general principle, most of the time the companies will want to keep that internal. And then patent it at the point where they think other people will catch up, then they would patent it. So the way that companies compete with each other, there can be significant benefits with competition, but the field as a whole it's extraordinarily sophisticated scientifically, right? Just to understand these data, you need to have a general understanding of neuroanatomy, electrophysiology, signal processing, and basically experimental psychology. And the idea that these things are going to be independently learned, and that companies will have teams together that will be able to do all that, I think is fairly. I think it's not very likely.
Yeah.
And so I think the electrophysiologic data. The other issue that we talk about sometimes is when these data are produced, who owns them?
Yeah.
Should those patients have the rights to their data fully labeled, with a sort of when it's in its maximal dimensionality, fully labeled at the sample the highest sampling frequency it was recorded at, without re-referencing, such that they can take that data and then share it. Right? We live in the age of monetizing data. Who owns these data? These data are very sophisticated, but also it's not going to advance without that.
Yeah, I have some ideas about that. So I think it's not fair to ask companies to share the data that they have, that they get out of it, because you need, and data, I think, is one of the biggest attractors for investors right now, because, the word data already gets people very excited. Brain data, neurophysiological data even more. So I don't think it's fair to ask companies to share those.
But
what data they own, that's a different story, right? So if I'm a participant, I should have a say over what happens with my data, other than what I agree with the company to train the models that I'm going to benefit from. But I should be able to say, okay, well, up to this point, I want to have these data.
But in the rest of medicine, patients don't give up the rights to access any data about themselves. Any note that I write, all of it, the patients have to see. They have to be able to access all data that we generate clinically. This is clinical data.
But can they tell you to delete those data?
From the medical record, under certain circumstances, absolutely.
Usually not.
Under certain circumstances.
Yeah.
So,
and for a patient to require a company to delete their data doesn't make any sense.
I don't mean delete the data. I mean share it. I mean make it so that it can be accessible to the scientific field.
I would like people to own at least part of the data, that they can do with it what they want. But I'm not sure it's very realistic.
Well,
I don't know how it's going to evolve in Europe. I mean, the ownership of the data is pretty clear. The person that generates the data owns the data, but you don't want to make it impossible for the company to use the data to train the models.
Well, I mean, they have access presumably to all of that data, but
but not necessarily. I don't know how it's going to go with the AI Act and the different.
I mean, we actually, and I should know the nuances better than I do because I implant a fair number of these devices. But the NeuroPace device that exists now, it records, decodes, and stimulates.
Right.
And those data are generated. And they're accessible by the company. They're accessible by treating physicians.
Do you have access to the raw data as a treating physician?
Yes.
You can download those data.
It's not a branch of research that I'm actively involved with. But I should be doing more with those patients' data. But we have so many branches of the lab already. But the company itself has been NeuroPace has been very good about allowing access to those data and allowing those data to be used for scientific purposes by any physician or team involved.
Only your own patients, then, I guess, right?
I don't know about when it goes to patients that are, because when they're not your patients, then they have to be anonymized.
Yeah.
And of course, that's the right thing to do. But should that be where the standard lies? I mean, a lot of medical data now are made proprietary and sold exclusively. I mean, if I wanted their databases now, or if I want to know about, let's say, surgical outcomes and the efficacy of giving different medications after surgery, there are large databases that have aggregated this, but those data all belong to individuals.
Yeah.
Should it be possible for you to say from your medical record, I want to press this button such that all my data gets loaded to a national repository? Now we're not talking necessarily about neurophysiology from the brain, but just in general. I mean, if people own their own data, then you should also, it would be like saying you should also make it so that they can, in an easy way, transmit it to a centralized service. Because otherwise you could just say, hey, we took all these notes and wrote all these things about you, but we wrote them in a language of our own construction with a cipher. And you can have all of it with a cipher.
I think
but you can't do that, right?
I think the realistic question is what would be the benefit of others having access to the data from a company. So, as you know, you don't get similar data from patients across the board, because whatever you implant is going to be what it covers is going to be individually different. So you won't have data sets that you can collate across different patients, because they're all sampled for different brain topography.
Well, I mean, in the literature, there's lots of examples of people doing this.
For this kind of data, I don't know. We never collate them. We just take one of the end results, like performance or something like that, and average that across patients, but not the.
I mean, there are there are manuscripts that I believe have been uploaded to preprint servers that have aggregated data across patients, trying to make general statements about how a whole brain region is organized.
Yeah.
Where that's each patient represents a sparse sampling, and you're assuming that the separability within one patient generalizes across, which of course we know.
I think you shared all the data that you had as a PhD student in one.
My data was all in the library.
Yeah.
So for electrocorticography, it's all published in the library. Our data that we have now gets published with the papers.
Yeah.
Some of the full data sets will roll out where we for our brain computer interface paper that's coming out now. It's just one channel, simple control with stereo EEG, but you can examine the network. Because our analyses are ongoing, it'll be the control channel that's released with the initial paper.
Right.
But then the full data sets will be later. But that's a
still,
different kind of a thing, and I feel very strongly about open data. But open data is an academic principle, not necessarily a company.
Well, and we don't do it as an academic community, do we? I mean, I would love to open up all our ECOG data, which is like many terabytes.
Yeah.
I would love to do that. The first hurdle is that, okay, how am I gonna make sure the data are understandable and accessible? So you have to curate the data hugely.
Of work.
That's a lot of work.
But we do it. I mean, I think that's
next is
what we should do as scientists. This is separate now from talking about just in
Yeah,
general with these data. They're so rare.
Yeah, but then
That
should
library
should
I
we
made-
require companies to?
No.
It's complicated.
Technically, the ability of a patient to potentially understand what their data are would be.
Yeah, that's
complete
fair.
set.
If you say, okay, well, a patient should have a copy of the data and they should be able to sell it to a research party or something. That's fair enough.
But that electrocorticography data set, I got an email from somebody from Turkey 2 days ago.
Oh yeah,
Who's using it. I mean, people use this all over, and
we share data.
insight comes from everywhere.
Yeah.
So I do think that
this is like 0.0000001 of the data that's collected, intracranial data.
it's 100% of ours. I mean,
You
yeah,
collect so much data, you don't put everything out there, do you?
With the
Because you have to
publications.
curate it. With the publications, yes.
yeah,
But
no, it goes
there's
out.
a lot of things that you don't necessarily publish that you
Our experimental
people
stuff?
could benefit from. But
It
you
goes
need to
out.
curate the data, and in my group, people complain of the yin yang because it's so complicated,
No, it's-
time consuming.
Your graduate student, Dr. Hermes, forces us to have it so it's in standard format.
Bids.
It's torture. Bids is torture. It's useful, but it's machine readable and all of that.
Yeah, I
but
know,
separate
but-
from that, it also appears in its condensed form that the last stage of analyses will happen in, or not the last stage, but you have all of the data sufficient to look at the brain data, co-register it as best as we're able to co-register it to anatomy, parameterized as well as we can in terms of behavior with it. And it's a lot of work, but it's the standard. Brian's paper that came out earlier this year on looking at electrophysiology of the thalamus, all of those recordings are there. So no, I mean, it's a huge undertaking, but it's the standard.
we have yet another problem, and there's the rule that if you want to open it up to any person to download it, which would be great, it has to be anonymized.
Yeah, absolutely.
For our BCI patients, it's impossible to make absolutely sure that it's not retraceable to a person, because there's only a handful of them.
Yeah, but their identity isn't disclosed.
No, in European, it's how do they call it? Pseudonymized. But if you can,
I mean, if somebody asks me, and I have this happen, I have patients all the time who say, "I'm so excited about, having this deep brain stimulation procedure. I met somebody in a support group who had surgery with you guys at Mayo, and they had this amazing outcome. And do you remember? And then they'll tell me the name of the person. And my response to them is I'm glad to hear you have a friend who did very well at Mayo, and that person will have told them my name or whatever. But under no circumstances can I, unless I've been given explicit permission, and people write
From
this,
that person, right?
from that person to share their identity. Even the people who've been under my care, I can't comment on it.
No.
And that's what's right.
Right, but when we want to, it's the same thing. But when we have, let's say, we have 4 patients implanted,
Yeah.
and they're all published on, except for the last one, it's recent. When we publish and when we open data up, our ethics committee is going to say, well, you cannot guarantee that those data are going to be retraced to one of those 3 people because there's only 3 people, and they are implanted in different periods of time. So the ability to identify who it is precludes us from calling it anonymized data, which means that by definition, we're not allowed to openly share the data, except for, you say, upon reasonable request to share the data. But we can't open them up to everyone, which we would like to do. So
That seems
that's
that seems
the goal.
holding certain values above others in ways that is protective of the people who regulate, not of the people who are implanted.
I'm not.
For example,
I'm
if
not
you
too harsh about it. It's a conflict. It's a regulatory / ethical conflict, because by regulatory standards we need to share all our data, because that's what the NIH wants increasingly, the EU wants it, and NWO wants it.
well, it's also that's a basic property of being a good, honest scientist.
Right.
Is everything you do should be reproducible.
But
now,
then
if you
then
give
hit
information
ethical
beyond that,
walls.
you're then a good citizen as well as
Yeah,
a
but
good
you hit
scientist.
ethical walls because it's the GDPR. There's rules about maintaining someone's privacy, even if that person is okay with you sharing their identity. You're not allowed because the law protects that person against themselves.
I mean, we have patients where we will show them participating in a surgery. They participated with us. They're awake and interacting, and we use this for educational and other purposes. And they're moving parts of their body, and you can see their identity. And technically, when you hear the sound of, and this is just for single units for DBS, when you hear that sound, that's data. That's even brain data. And those people, they're physically shown, but that is explicitly part of the consent process for educational purposes in the beginning.
It's the same
and then
with
it's a
us.
secondary.
Yeah.
We get a secondary consent for filming. So,
But we're not saying different things.
oh no, I know. I'm not saying that what you're doing. I just think that the idea that patients would not share their brain-computer interface data because they could potentially be tracked back. Any person's data with sufficient level, if you give a sufficient level of detail, they could go to have an EEG somewhere, get a topological fingerprint, and say that if I regress this down to whatever.
Yeah.
Down to the stereo EEG, most superficial contacts, it's grossly the same topology, so it's probably the same patient. I mean, there are exotic links you could go to.
That's
for
not
any of this.
identifiability. It's a one-to-one match of different databases. That's what people worry about.
Yeah.
So this person has, it lives in a particular village, in a particular blah, 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 at a particular age, then people will be able to link those two one-on-one. So that's the struggle.
But their photograph is also personal data.
People share a lot of data on the internet.
Yeah.
Much more than anyone that I would care for. But that's their free choice.
Yeah.
But if I have their data, I have the responsibility to protect them against themselves. And there's the ethics protocols that make sure that I do. So there's a limit to sharing data, and I know parties that want to share a lot of data, and they for those two reasons they just give up. It's the curation costs, and it's the struggles with
The curation costs, as a scientist, that's the price you pay for recording data.
If we collect data in our BCI patient, that's like gigabytes with different conditions. That's a lot of curation to get that all right, unless you have fabulous software that puts down everything at the same time. But I haven't seen that yet. There's a lot of different data channels that need to be put together and in bids,
I mean, I'm
IBIDS
thinking about
format.
it at the stage of publication. The data need to be.
Yeah, but that's only the publication, but we get like 100 times more data than we publish.
Sure.
And then they all need to be curated.
So the 1% that's significant gets published and the rest gets.
No.
And then the last thing, do you think that at the time of implant, there should be sustained financial commitment either from a company or from the hospital that's implanted to take care of issues related to the implant down the road? So in America, things are a little bit more complicated in the way that healthcare is paid for than they are in the Netherlands. And so you can wind up with a situation where people can't get something that was implanted taken out and they very much want to. And I'm not talking about the stuff that goes in the brain, I'm talking about wires that are elsewhere.
Yeah.
And I mean, some solutions that I've thought about would be you have an institution like the hospital make a commitment, or you could say a company makes a commitment, but the truth is that a lot of those companies, if they're startups, may not be around. And so do they put money in escrow that then gets, what's the system? Or if you want to do these studies, should the institution that you're a part of make a commitment? How should that work?
All of the above, I imagine. It's just, there's no system in place, but I know there's in ethics/regulatory context, there's a lot of discussion about this. It's like device abandonment by the manufacturer, or we're in the same bundle. If we don't have grants anymore and the group disappears, then there's no one. The hospital. I'm quite sure in Holland the hospital will take care of it.
Yeah.
But their only option will be an explant or a partial explant.
Yeah.
I really don't know how to solve this problem. The only thing I can imagine is, okay, well, right now when it's a research participant, it's the responsibility of the hospital to make sure that it's ended properly. If for any reason, but I don't see a solution there. If the device really works very well and it breaks down and we're not there anymore for whatever reason, there is no other option than explant. So that's just disaster happening. And so by the time they're commercial devices, I think the major solution would be a connector. So you can switch to another manufacturer, and that's why I think.
Yeah, that's why I think there should be modularity and interoperability.
Yeah, because you just can't replace the electrodes under the skull.
I think it's like somebody should write a small, brief article that articulates these
Oh,
things.
really?
I'm never going to stop giving you a hard time now, even after you wrote it.
I'll read it.
Yeah, I'm sure you will. Yeah. All right. Well, I really enjoyed having you.
Absolutely, yeah.
You've been a wonderful scientific mentor of mine and a wonderful friend. So thank you for that. I'm glad we got to have you on the show.
Yeah, thanks for being here. It's been good meeting you as well.
Yeah.
And thanks for tuning in to the Stein Fireside Chat. Look forward to seeing you next time. Thanks a lot.